Welcome, everyone. Welcome to this month's HSPN monthly OHT webinar. Please, if you're joining in now, if you could go to the chat and open the chat box. And once you get the chat box open, please let us know who you are and where you're joining us from. Please make sure that you click to everyone and not just host and panelists. There, thank you. Welcome. We'll just see. As people are joining, I can see that people are joining. Monroe Ross from Great River, first one in. Great to see you, Monroe. Brenda Fulmer from KW4, welcome. Megan DeRoche from Ottawa West Four Rivers. And thank you, Dale, now Senior Manager of National Policy for AstraZeneca, formerly with the ministry. And Shana Smith from Ottawa. Please continue to type into the chat who you are, where you're from. And I know there are a lot more people than that because I can see the online folks. Brian Schnark, thank you. Kathy Slevin. And I think, Kathy, you were probably on the one this morning as well. So big day for webinar time for you. Hi, Ash from KW4. Lovely. Thank you. Please continue to enter into the chat who you are, where you're from. Really great to see people coming from all corners of the province and also from our ministry colleagues. Welcome, Jeff, for joining us today. Thank you. I would like to acknowledge the land from which I am today. I'm at the University of Toronto, and for thousands of years, the University of Toronto, the land that we have operated on, has been the traditional land of the Huron-Wendat, the Senecas, and the Mississaugas of the Credit. It is still a meeting place and home to many Indigenous peoples from across Turtle Island. And I know that I am very grateful to have the opportunity to have my place of work on this land. I also live in the city of Toronto, very nearby, and I'm able to enjoy the many areas and geographies and some of the natural landscapes that we still have around. And I do know that I pay attention to some of the geographies and how that has, from time immemorial, been traditional trails and meeting places for the peoples of this land. Today, we are, in our webinar, continuing to talk about the learning health system. And we are taking a little bit of an in-depth view. We had an overview first from John Lavis, Rob Reed, and Maureen Smith to talk about this and how it was designed and what it was intended to do. And I invite you to continue to look at the action framework that's available through the Ontario Spore Support Unit website. And there's a code in the corner, but if you look up Learning Health System Action Framework, you should be able to find it quite quickly. We're looking inside the gears in our series here. So we've started last month with analytics and population insights. And today we're going to get into evidence synthesis. And there's two ways to think about evidence. One is synthesis of evidence that's coming in. So you may have a topic. This morning, OHTs were talking about different pathways and different models of care that they were being implemented. You might think about an evidence synthesis to be able to inform that work. So rapid synthesis of existing evidence to understand success or failure of solutions to similar problems that have been tested elsewhere, as well as barriers and promoters. And this is thinking about what can we do and learn from in order to enhance what we try to implement in our OHT. Sometimes you will be into new areas, however, that there isn't a lot of evidence, particularly if you're looking at integrated models of care. There's not always a lot of evidence available to you in those areas. And you'll have to think about how do you generate evidence, or how do you think about evaluation within your plan in order to generate the evidence, and then you can know whether it's working or not, and also to be able to share that. So we're going to represent all of these perspectives today with our panelists, and I'll introduce those just after you clue in and let us know if this is your first time joining with an HSPN webinar, or whether you have participated previously. So have you joined us previously? And if you can join in and click on this poll, thank you very much. Pretty quick responses in, and I always think it's amazing. We can share this poll back out now. I think there's almost all the respondents are in, and we can see that 72% have participated previously. We have a good recurring audience here, and I think some people are here almost every single month. But almost a third of people are in for their first time. So we continue to attract new audiences. So I really appreciate those new ones. And I think hopefully you're here for the topic. I say people come for the topic and stay for the chat. Please do engage in the chat, because I think we're going to have both good chat and a good response from your participation today. Okay, so without further ado, I want to share and introduce our speakers today. We have people coming from all parts of the province. From the north, Dr. Diana Uranek and John Hogenberg. They are the director and associate director with the Center for Northern and Rural Health Research. Diana is also assistant professor, co-chair of social and population health at the Northern Ontario School of Medicine University, and cross-appointed at the School of Kinesiology, Health Sciences, and Department of Psychology at Laurentian. Diana is providing leadership for the center through many activities, and I'll highlight a few of these, including patient-oriented research, digital virtual care, and many other supports. John is the associate director, and his research is focused on health services for rural and underserved regions, incorporating investigations into health workforce, digital health, and virtual care. And both have worked on projects with Ontario health teams, maybe some participating. After that, we're going to hear from Dr. Justin Perceau, who's the program director for the Methodological and Implementation Research Program at the Ottawa Hospital Research Institute. And he's the scientific lead for knowledge translation at the Ottawa Methods Centre. He's going to talk about a lot of the activities and supports that the Ottawa Methods Centre has. He leads a multidisciplinary program focused on drawing behavioral and implementation science to support health and well-being of patients. And I recommend you check out his website. It's got some pretty neat things, but he's going to speak more broadly, I think, to the Ottawa Centre and the region. Finally, Kellen Moat. Kellen works with the McMaster Health Forum. He's also a keen participant in many aspects of RISE. Many of you may have encountered Kellen through his work with RISE. And he plays a leadership role in establishing the world's most comprehensive free access points for high quality evidence about how to strengthen or reform health systems. So really the evidence synthesis side is the area of Kellen's great strength. And he's going to let us know about many of the resources that are available through the McMaster Health Forum and show and tell and a learning for the future. So really great opportunity today to learn and an opportunity to share in some of these excellent programs. So first up, we will have the Diana and John, and so I'll turn it over to them to lead us through their work.
Thank you, Walter. Good afternoon. So it's a real pleasure to be here. I'm Diana Urashnik, the director of the Center for Rural and Northern Health Research at Laurentian, like Walter has mentioned. And along with my colleague here, John Hogenberg, we are very happy to be here today and to have this opportunity to share our expertise and the supports and the services that we have in place, or some of the ways that we can and do support OHTs for your evidence needs and the work that you do and that you can leverage to enhance your care initiatives within your OHT, along with some examples of our work with OHTs and lessons learned. Next slide, please. So this is our mandate. So we're an applied and academic center, health research center at Laurentian, like I mentioned, in Sudbury, and since 1992. So we've had quite a long history of being here in the north. And consistent with our mandate, we do conduct northern rural health research and evaluation to improve health services and access to healthcare with an equity lens. So equity is a very large focus for us. And we take an interdisciplinary and multi-method approach to what we do, and very much an applied approach within context and within the health system to support the system. We're also one of 14 centers and a number of initiatives under the Ontario Sports Support Units. So I know Walter had mentioned OSU earlier, or OSU is the acronym, the coordinating center in the province for the Provincial Sport Initiative. We're the northern partner within the broader network with patient and community engagement and capacity building, learning health systems work, and work with data platforms and evidence generation and use, all within our mandate. It's really our broader approach, and we bring the northern and rural perspective from our center, and we lead a couple of initiatives within the context of those things, which we don't specifically have here on this slide, but is reflected in the services and supports and the work that we do across our areas of expertise. And next slide, please. And here we have, oh, I think we have to maybe go, oh, no, it's poll number 2. So we're going to do another poll. So before we go any further, we want to ask you, so who supports your OHT's local data analytic and evaluation activities? Who supports your OHT's local data analytic and evaluation activities? Do you have dedicated researchers, evaluators who provide these services for you? Do you partner with, to obtain these services from your partner agencies, with external organizations? Do you have partnerships with academic institutions, or do you rely on academic institutions to provide these services? And if there's any other constellation of what you might do, please let us know in the chat.
And I don't know, Diana, if you can see the poll, but it's still, people are still peppering in. So we're going to leave it open for another moment or two.
Thanks, Walter.
Yeah. And there are longer things, a couple of these extra options. So do let us know in the chat. Some people are choosing the other, where you have partnerships. And it may be that you have none. I just realized we didn't really leave that option out there for you. So maybe you could put that into the chat as well. But if you do have other opportunities, please drop that into the chat. Maybe you can share the results back out. I think, can you see this?
Yes, yeah, I can see it. Thanks so much, Walter. So we obtain these services. So 66%, 2/3, you obtain services from your partner agencies. I think next in line here is we have a dedicated researcher, evaluators who provide these services, and then followed by other. I can't see what the other responses are, but there is other here. And we obtain these services from external organizations, to a lesser extent, along with relying on academic institutions to provide these services. So thanks so much. Next slide, please. Now, having come out of that, Paul, how should local data analytic and evaluation services be supported and organized? Okay, and try to choose one here. So fund one or more researchers, evaluators in each OHT, sorry. Fund several researchers or evaluators operating at a regional or a sub-regional level, purchase services from consulting firms or other experts, or build capacity within HSPN, RISE, Inspire PHC, etc. Expand the role of evaluation coaches within the work that you do and the supports that are out there. And then again, if there's anything other, please feel free to let us know in the chat. So how should local data analytic and evaluation services be supported and organized in order to meet your needs for your care organization, your OHT, your care organizations for the system, in terms of evidence generation that will inform your ongoing work? How should local data and analytic and evaluation services be supported? We'll just give you a minute there to pop those in.
Yeah, and we had at least one participant mention that they weren't in an OHT. So on this question, I might even ask, if you're not in an OHT, what do you think how OHTs, what would make the most sense for local data analytic and evaluation services? What do you think makes the most sense? So even if you're not currently practicing in an OHT looking for help, what do you think makes the most sense? And then Monroe had a question about funding. I'd say the funding would mean, Diana, I think this was, or John meant more around like OH or MOH central funding, and purchasing would be more about from local funds. Is that right? Or who would be funding?
Well, that's certainly an option, but you know what? What we would love folks to do is to put in the chat, is there any other kind of constellation of funding or idea that would make most sense for you or for the system?
Okay, great. Maybe we can end it and share the results back out. But people should be popping into the chat.
So fund several researchers, evaluators operate at regional level is 40, just under half of responses here. Fund one or more researchers, evaluators within each OHT at a quarter of responses here. And then following this is build capacity within HSPN, RISE, Inspire, PHC, et cetera. And then to a lesser extent, no one for expand the role of evaluation coaches, but purchase services from consulting firms or other experts is, and other, I'm not sure what the other would be. And maybe Walter, you can make a couple of comments on that option.
Yeah, thanks. And I think there are a couple questions coming in around the chat, but I think one of the things that some of the suggestions being how are resources allocated out to the Ontario Health teams, and I think one of the questions I had and was talking with some of the folks in the north. Is in some cases it's, and I have a question towards the very end of today about thinking about equity, is if it were dollars, so there's a session, provide the funds to the OHT and the OHT can figure out how to allocate and purchase them. But, I know I've talked to some of the OHTs, particularly in the later wave, some of the smaller ones starting up, they can put up job ads and there just actually aren't necessarily always the people available, local resources everywhere. In order to power. And so sometimes it actually might make more sense to provide more centralized supports across a region or to a number of OHTs. And I know we've had some groups a year ago this month, we had people from NHS England where they were supporting the integrated care systems, integrated delivery systems in their system. Our webinar was focused on equity, but they had sort of central resources, a staff of 25 or so that each had 2 integrated delivery systems that they supported. So it's kind of like an OH type model where they centrally had a pool of people that worked together and collaboratively, and then their jobs were entirely dedicated to supporting the local teams and were directed by local teams in their work. So there are different options. So I think that's some of the considerations as well. And Brian commented that it was happy to see several at the regional and sub-regional level because some OHTs are too small to have critical mass. So I think that's exactly the point I was making. So thanks. I think we have one more poll around people's experience with this.
Yeah, and so just to take it from there, so how useful for your OHT are the existing data analytic and evaluation services that you have access to? And choose one. So from not useful to highly useful. And then in the chat, please suggest how, these services could be made more useful to your OHT. So how useful is what you already have in in your practice, everyday practice? I'll give a couple of minutes here for folks to populate. And please suggest how these types of services could be made more useful for your OHT. It's really important to do so, so we can take away those learnings, and we all can. So how useful are the existing data analytic and evaluation services?
Okay, well, I think this is sort of conditional on people having access to services. So maybe we could share the results back, and then the chat's starting to pop up a little bit now.
So moderately useful, 13% highly useful. So, and then half moderately useful. There's a spattering here of neutral, 13%, slightly useful. So there's of some use, 22%. And then there's a minority here out of the responses that are just not useful at all. So moderately useful seems to be the most popular response here out of the responses that we have.
Great. And I also see some suggestions like Rain Hindley's suggesting it'd be good to have an inventory of available data sets and resources. And I know that through RISE, we've tried to make the platform so that people can see and access what resources are available, but I can understand, and as more accumulates, actually, we need to maybe come back and see about some of those sets. I'll speak a tiny bit to some of the things that are available at HSPN at the end, but also making sure that this is clearly available to all OHTs. And I think having a single portal for that sight line makes the most sense. And we're trying to make RISE supported in doing that. Okay. Thanks very much for these. And I think we're going to learn a little bit more about Craner now.
Yeah, so thank you so much, Walter. So it's really nice to see, your engagement in your responses. And so, this is our, an opportunity to share our expertise and the supports and services that we provide. And so, broadly speaking, and you'll see here on the slide, and these areas aren't necessarily mutually exclusive, but we engage capacity building, for example, for internal evaluation processes within organizations and systems. We've also had, you'll see here, we've had an employee at Craner embedded as an OHT fellow in the first wave of the program, although it is no longer. Document analyses and literature reviews, including rapid reviews and knowledge syntheses, and program evaluation. So we assist with needs assessments and process and outcome evaluations at various stages. For example, we might develop a framework at the inception and development phase, or come in at the data extraction and evidence synthesis phase, or be involved throughout for the work that we do. And the same can be said for the continuous quality improvement work that we do for stakeholders and partners. So evaluation and CQI supports to healthcare organizations, and we've often helped in conducting smaller scale assessments of needs and services for client populations that require complex care. For example, people experiencing disabilities, homelessness, and addictions, and using data, excuse me, and using data for internal evaluation and evidence synthesis processes. Next slide, please. Areas of expertise, which I've mainly mentioned, I believe, are in patient-oriented research and incorporating equity, diversity, and inclusion, and Indigenous perspectives, and Francophone perspectives as well, given the rural and Northern health perspective that we bring. And explicit consideration of minority and marginalized populations, for example, for the populations that, of course, we do serve here in the Northern rural context. Local, regional, and provincial level assessment of health service access and use, And within primary care, like when we think about the services, in that primary care, acute care, community and long-term care, mental health and addiction services. And we also have a long history of exploring health human resources issues in rural and remote communities. And with the assessment and modeling of the health workforce as well. The evaluation of digital virtual care programs, beginning with the earliest days of the OTN, in fact, and incorporating a learning health systems approach as a way of thinking and doing, and with OHTs as an embedded partner and with our work with OSU for sure. And you'll see that at the bottom of the slide here. It kind of brings us back to the beginning that we are an OSU center, as part of our mandate. And I think the point here in moving along is to convey what we do and the areas and the ways that we can support OHTs. But the important thing here is translating that to what this would look like on the ground, right? And lessons learned from our work in bringing the northern and rural perspective and the issues and challenges and the strengths and opportunities that OHTs are experiencing and leveraging that to potential solutions. And in listening to OHTs, to what your needs are within your context. So a contextual, collaborative approach here that you'll see on the next slide. And I'll hand it off to my colleague, John Hogenberg.
Thanks very much, Diana, and thank you to Walter and the team for the invitation to speak, and of course for folks here online who are listening and looking at what we're saying. So, one of the things I think we bring to our interactions with OHTs and our other partners is that it's really a collaborative approach where the partners set the agenda. So if you have a need, if you have an interest, if you have a question, we're there to help. We can bring our expertise and our knowledge, but you are the context experts, and we're there to assist in any way that we can. Diana mentioned rather that we build capacity within the organization. So part of that, our role rather is to help with that, and we're quite nimble in terms of what we're able to do. There's a list there of some of the technical skills that we bring, and I won't go through that. So if I got the next slide, please. But they're pretty standard stuff related to research, evaluation, CQI, so forth, and so on. But what do we do? Well, at the very basic level, we provide data analytical support. So this is framework development. It could be data collection and extraction, analyses that are targeted to the specific questions that you might have, and then shared interpretation. I think this is crucial. We could bring our expertise as sort of data experts and information and research and evaluation experts, but the context is something that the local OHTs and other experts need to provide, and that's where the shared interpretation comes in. We can help with regional coordination of data requests, because the care that is provided isn't just in the local hospitals or primary care organizations, it's throughout the province, and there is interflow and interconnection, not only the patients, but the data. So we can help with that, and again, help provide some of the local context or help with the interpretation from a local perspective. And then, of course, it relates to what do you do with that? Well, not only are you going to look at the programs that you're implementing and seeing whether they're working or not working, but what can you use that towards any strategic planning and responding within the ministry requirements and OH requirements, but also within the requirements of the various agencies that make up your OHT. Next slide, please. So we've been doing our direct work with OHTs for a few years now. I mean, as Diana mentioned, the center's been in existence since 1992, and we've had a long and successful history with working with folks in the north. And since 2020, basically soon after the OHTs were announced, we've been providing support at various levels within that. You've got to do the work, but you've also got to share it. So we're big on sharing the work that basically runs the gamut of formal reports, formal presentations to informal discussions and consultations and policy briefings and email blurbs and whatever is needed to communicate the findings and communicate the importance and the interpretation therein. Next slide, please. So just some examples there. We've looked at basic things like the demographics of the attributed populations and the resident population. We know that OHTs are premised on the attributed population, but we also recognize that there are catchment areas. Folks still have a fairly strong geographic perspective when they talk about patient care and patient services. And so there's some overlap, obviously, between the people who are part of the OHT and live in your area, but or are part of the OHT and don't live in your area and maybe closer to some other location, some other OHT. So there are some differences and similarities there that are important to consider when you're thinking about planning, and also when you're thinking about evaluating the data, evaluating the program using the available data. We look at attached, unattached, and what a colleague of mine has called loosely attached patients. So by that, we mean that within the attributed population, you have a rostered group, which is pretty strongly attached to primary care. That's about 80% of the population, and I'm rounding things here, as you can appreciate. Approximately 10% in addition to that are what folks have been calling, or my colleagues have been calling, loosely attached. And that's really those that are either virtually rostered, which doesn't mean virtual care, but it means that they're seeing primary care physicians for their care and going to those locations for their care. Their children in the area, they're going to CHCs. It's that group that are not formally rostered, but are basically attributed to the population. And in the old frame sense of the word, there's a lot of those folks are unattached. They're not, by virtue of the definition, they're not rostered. So it's important to understand some of those differences. And what do we look at? Well, there's a couple examples here that follow, or more than a couple there. We're looking at emergency department visits by CTAS score. We're looking at some of the social economic characteristics of the populations, again, attributed in resident populations, mental health addiction, x-rays, that kind of stuff. Who's using it? Where are they going? Where could they go? That kind of thing. And I think what's important, particularly for some of the larger areas, not only in terms of larger geographies, but larger patient populations, is, are there differences within those groups? Are there community-specific differences? Is one community more inclined to do this or less inclined to do that, or has a greater number of patients who perhaps have diabetes or a lower percentage, and so forth and so on? So we recognize that within OHTs, there's the attributed population, there's the resident population, and within the resident population and the mix of the two, or the combination of the two rather, there are some differences, again, by geography that are important to pay attention to, or at least look for to see whether they are important. Next slide, please. So, what can we say in conclusion? Well, we as a center, we advocate for basic patient-oriented care and facilitate evaluation and research and CQI in the context of a learning health system approach. But what does that really mean from the perspective of a OHT? So what it really means, at least from my understanding, is that with a learning health system approach, that Craner works with OHTs to more fully integrate practice with evidence gathering, analysis, and interpretation, right? And what that enables is a collective approach, a collaborative approach that is responsive to the needs and circumstance and provides the tools, the data analytic tools, the interpretation tools, the framework tools to help OHTs achieve their mission objectives. So that's really, what this boils down to. So you can see the contact information there. I should clarify something that we didn't clarify earlier, and I apologize for that, is that Craner actually has two sites. So we have a sister site in Lakehead University in Thunder Bay. We're based in Laurentian. We work with each other on a variety of projects, and we'll collaborate as need be, but the stuff that I'm speaking to you today is really about the work that we've been doing here at Craner Laurentian. So with that, I'll close and turn it back to Roger turn it back to Walter, and thank you very much for your time and attention.
Yeah,
Thank
thanks
you.
very much. And thanks, John. Thanks, Diana. I think it's been a very, very interesting tour to learn about the projects, and I think and your engagement already with Ontario health teams. And I think, one of the things that's really important about Craner is their experience in living in the North and understanding the different approaches to care and what the relationships are like amongst the different communities. And I think that local context can be extremely helpful. You can assume some knowledge that you might have to be explaining to people like me who have done some work in the North, certainly been working with OHTs, All Nations from the very beginning, and then a number of the other teams along the way, and now looking at how we might support through RISE and HSPN collaboration, through some collaboratives in the North. So I appreciate that, but I really think that the excellence that Craner has and the specialization is very, very useful. So feel free to add more questions to the chat, and John and Diana are going to be with us, so they'll be able to answer those, and they've got their contact information here so that you can advance your connection with Craner. So I want to now turn it to our next talk and presentation, and again, engaging with Dr. Justin Perceau, who is joining us from the Ottawa Methods Center and the University of Ottawa as well. So Justin, I think you've got a little bit of an overview of the broad program, as well as maybe some tidbits from your own areas of expertise, and I know you have them from the implementation science side, the evidence synthesis side, from many different angles here.
Exactly. Thanks very much for the opportunity to speak in this webinar today. And bonjour à tous, welcome everyone. Bonjour à tous qui viennent du côté francophone ou bilingue aussi. I'm looking forward to talking through exactly as Walter described how the Ottawa Method Center in particular might be, alongside my colleagues from Craner, another resource that you might be currently drawing from or could draw from more in the future in supporting your work. Next slide. And what I want to make the case for is really that that Ottawa and the Ottawa Method Center in particular really provides expertise for each gear in the learning health system, and can operate, and we operate very much as a hub for that type of expertise, not only within gears but across these gears. And I'll give you a couple of specific examples of how we try to make those connections. Next slide. So the Ottawa Method Center, really, I hope if you don't know about us, that you see it very much as an infrastructure that you can draw from. It was established in 2006, but now includes over 30 methodological specialists that span 9 different specialty areas, which I'll talk about in a couple of minutes. And the types of clients that we serve within the Method Center include the scientists and clinicians, trainees, students, and researchers, but also government and healthcare organizations more generally as well. And so we like to see ourselves as very much a methodological one-stop shop for engaging in multiple processes across the learning health system. Next slide. So I thought I would start off by sort of gauging the audience in terms of whether you've heard of us, how familiar you are with the Ottawa Method Center altogether. So you should have that poll up.
Yep, the poll's up. So people are now coming in fast and furious on this one. This is a general one that applies to everybody.
Exactly.
So it's clear. And I think we're going to be, there's a few more people popping in. Okay, perhaps we could share the poll, and I'll leave it to you to interpret as you see.
Okay, so mostly speaking to an audience that is relatively new, which is really exciting for me and for us. And hopefully we can move these numbers down more towards the bottom after the end of this presentation. Okay, next slide, please. Okay, so in terms of what we do, and I mentioned we have sort of 9 areas of specialty focus. So on the left-hand side, it's sort of cross LHS perspectives in really design, methodology, data management, backend, and outputs and publication. But then the center column and the column on the right is really the core of the gears. So we have expertise in knowledge synthesis, in big data analytics. So when we're talking about data linkage, ICS data, or down to more specific biostatistics expertise, have health economics expertise, patient-oriented research, as well as knowledge translation and implementation science, which I'll talk about in a bit more detail. So thinking about these 9 areas, I'll move on to the next slide and the second poll. I'm interested in, amongst those, what services within the Method Center might be useful to your team and organization. I think we've pitched it as a single choice. So what would be the most useful, I guess is how you can interpret it. And also, if you're unsure, you can choose that one as well.
Yeah, I'm sure that, and also maybe use the chat, because I think this might have, clearly many of these services could be quite useful. And I think that was just a glitch on our side to put it up as a single choice on this particular case, but put in the one that is most pressing front of mind for you today, and then use the chat to maybe add in some of the others that you also think would be quite useful. And I see that people are still peppering in many different options here. Your center has a wide variety of resources. I think that quite available. It slowed down a lot, so maybe Tricia, you could pop up the results. Thank you.
Okay, fabulous. So quite a spread as you're indicating, Walter. So that's great. Fantastic. And unsure, tell me more seems to be the winner, which is exactly why we're here. Fabulous. Okay. Next slide, please. So as I mentioned, we very much see the expertise that we can provide and in partnership with yourselves as fitting into all the gears of the learning health system. And I wanted to walk you through a couple of examples before deep diving a bit more into what we're here today, more specifically on around the evidence synthesis and support. So next slide. So one of the resources, which I'll just spend one slide on, is in the central gear of the whole LHS around patient, family, caregiver, and provider co-design, is we've established what's called the Office for Patient Engagement in Research Activity, or OPRA, website being there, where we have resource staff within this office that really focuses on how patients and caregivers and provider and family members can partner in the whole process, whether it's to support identifying potential patients or people with lived experience, engage them in the study or evaluation design and thinking about training for them, help them to be a part of the process of developing research questions and broader engagement research methods. So if this is an area that might be of use within your OHT, feel free to directly reach out to our OPRA folks within the Method Center. Next slide. The second gear that I want to emphasize is around implementation, which isn't going to be the focus of today's webinar necessarily, but wanted to emphasize that within the Ottawa Method Center and Ottawa in particular, we have a dedicated center for implementation research that assembles 14 multidisciplinary, interdisciplinary experts in implementation science. It was established in 2018, in fact, January 20th, 2018, and you might ask yourself, why do I know that so specifically? Is that on the launch date of our center happened to be the date that my daughter was born, and so that one etched in my mind forever. But what our Implementation Research Center provides expertise in is very specific areas of implementation science, and whether it's leveraging data for feedback to teams or providers, developing rigorous decision aids, evaluating clinical practice guidelines, as well as the methods such as evidence syntheses, qualitative survey, consensus methods, in intervention evaluation, barriers assessment, and intervention co-development. And so it's really a deep dive for the implementation cog. But next slide, please. Really what we're here for is this evidence synthesis and support. So I wanted to give you a sense of a couple of examples of how our team at the Method Center has been involved in leveraging evidence synthesis that have been requested by government or external organizations, and indeed facilitated by the team at McMaster Health Forum that you'll hear from next. And just give you an example of how leveraging those types of rapid evidence synthesis can be built into the whole LHS process. Next slide. So the two that I'm going to focus on are what's called the optimized platform, which is our COVID-19 experience, and then I'll talk about the Diabetes Eye Screening Ottawa example. Next slide. So within the pandemic and facilitated by Kaylin and the broader team at McMaster Health Forum, there were requests coming in from the ministry or the Public Health Agency of Canada around different areas of response to the pandemic, and the expertise that we could bring from an evidence synthesis perspective is rapid responsive evidence syntheses, often within less than a month, to summarize what we know, for example, about what's affecting at the time acceptance and uptake for vaccination in different groups, and understanding risk perceptions, understanding the relationship between mandates and trust, looking at what are effective interventions for promoting adherence to public health and safety measures. And some of these were living reviews, so we would update them every couple of weeks so that we could provide the evidence as quickly as possible to our requesters. Next slide. So what we would be able to provide, for example, is even up to earlier on in the pandemic, there was already 175 studies in August 2021 of people looking to see what is stopping or helping people to consider COVID-19 vaccines. And what we're able to do is summarize what is coming through the qualitative and survey literature as this particular example, and then categorize them using particular frameworks to make it easier to digest those 175 studies to make more actionable recommendations going forward. So that's just an example of the kind of expertise that we could bring to an evidence synthesis. Next slide. And what that particular example provides is, set the stage for, is that we could draw on that synthesized evidence. And what we did was establish what we call the optimized platform, which ended up being funded by CIHR and is a partnership, in this case, with public health units and community leaders in 3 cities, where we are coming in as a team to provide support to the public health units and further developing partnerships with community members that were underserved and not at levels of vaccination targets that the public health units were striving for. And I want you to see this as an example of how evidence synthesis can be linked into partnerships and the specific supports that we can provide. Next slide. So what the key steps really within this process were that we wanted to make sure that we prioritized underserved groups using data from the public health units themselves, and they determined which groups and which areas we focused on. Co-lead with patient and citizen partners, including Maureen Smith, who you've heard from, I think, in the past. Some of you have attended these sessions. Connect with community leaders to reach out to community members to hear directly from community members what is affecting their decisions, and then work with community members to develop strategies that could be brought back to public health units to support them. Next slide. So what that enabled us to do is we leveraged data in the earlier phases of that learning health system in each public health unit separately, that they specifically identified either areas of the city, certain doses of the vaccine, or certain community groups within their city that they wanted us to support alongside what they were already doing. So you can see these examples here. Next slide. And then that enabled us to engage with community leaders in each of we developed relationships with community leaders in each of those cities, had a number of meetings that were led by patient engagement co-leads, in some cases in multiple languages, with a focus on trust and culture and linguistic competence. acknowledging historical injustices where relevant, for example. So these are the types of things that our team can bring to bear alongside in our partnerships. Next slide. I won't go into the depth of the details on this slide, but what I wanted to emphasize is that by going through this process and community partnership, connecting with public health units to identify those, we're able to reach out to people in each of these communities that honestly, I don't think we would have otherwise been able to do had we not gone through this partnered process of community engagement and partnership with the public health units. Next slide. We also went into this knowing that the public health units were already doing fabulous jobs in the jurisdictions that they're working in really challenging situations. And so what we wanted to do is do our homework to make sure that what we were working on and recommending back as a consequence of the partnership work that we're doing is complementing and adding value, not just repeating what's already been happening. And so this is another piece that we can provide, is making sure that we're using multi-method approaches to get a sense of what sort of strategies are already being used. Next slide. And we had a process for engaging people with lived experience in the different communities to develop strategies to bring back to public health units, and then develop policy briefs so that they could be digestible recommendations for the busy professionals within public health units. So a more transparent and direct process back to our partners in PHUs. Next slide. So that's an example, sort of COVID example. I also wanted to give you an example of a more integrated approach between community health centers, community groups, and tertiary care and hospital programs. So this is the Diabetes Eye Screening Ottawa program. Next slide. So just quick context around this from a clinical perspective around diabetic retinopathy, very common microvascular complication, one of the leading causes of sight loss, if not detected and treated. Rates for screening are relatively low across Canada, and particularly lower in people that have immigrated to Canada. So for example, in Ottawa, data pre-pandemic, 40% of people had immigrated to Canada with diabetes hadn't had their eye screened in the last 2 years. Next slide. So what we wanted to do from an evidence synthesis perspective is do our homework. So we wanted to see, what do we know from the rest of the world around why don't people get their eyes screened? And so we were able to identify 69 interview and survey studies, and then not just identify those, but using particular frameworks to just categorize what are the factors that are preventing people from coming in to get their eyes screened. So a number of different factors identified, and we noted that only 3 studies out of the 69 were in Canada, and only 1 was within a minority group. So that gave us some pause for some future work. Next slide. And we also wanted to do our homework, again, with an evidence synthesis around what works to increase screening attendance. So we partnered with folks with expertise, clinical expertise in this, and identified 66 trials that have tested strategies to see how can we get people to come in to get their eyes screened, and then did a deep dive on particular strategies on the right to see what particular elements of outreach programs really help to get people through the door. Next slide. But we were really interested in that immigration to Canada perspective and working with equity deserving groups. So we took some time to deep dive with 39 interviews conducted in Urdu, French, and Mandarin in Ottawa and Montreal to really get a sense from different communities, equity deserving communities, what were the specific challenges that they faced in coming in to get their eye screened. Next slide. Which all came together to enable us to get some funds to co-develop and establish a new community health center-based telemedicine eye screening program to address some of the barriers, including cost, wait times, access, which was developed as an integrated care partnership between a CHC, Centertown Community Health Center, that hosts our regional diabetes education program, with the Ottawa Hospital Research Institute and Method Center, as well as the Ottawa Hospital Eye Institute. Next slide. And so we went through a number of processes of co-design through that as a consequence of being able to draw from those evidence syntheses and those primary studies with community members. So we partnered, did a number of co-design workshops in multiple languages, and including health system partners. We purchased a state-of-the-art camera that could be housed at the CHC to enable a task shifting intervention, so that rather than optometrists or ophthalmologists who are busier and less cost effective in this process, and instead having a trained screener based at the CHC to do the screening, upload images securely to the Ottawa Institute for grading and follow-up treatment and care as needed. So that's been a successful integrated partnership within the Ottawa setting, and all drawing on that initial, those that doing our homework from an evidence synthesis perspective. Next slide. So this is my penultimate slide. It's really just to emphasize with these two examples, one or two of many that we could have flagged, the two that I've been involved in closely. But really evidence synthesis and support can provide that foundational perspective that can lead to the rest of the gears in the learning health system. And from the Method Center perspective, we can definitely support you if interested in drawing from some of the state-of-the-art approaches in implementation science in particular to do things like synthesize barriers to implementation, synthesize what we know about acceptability of new interventions and effectiveness of different interventions. Last slide. And so if you're interested, I haven't been able to follow the chat because I've been speaking so quickly. Apologies if it's been a bit too quick of a whistle-stop tour. But if you're interested in leveraging any of the expertise within the Method Center that we've talked about, you can put in a service request directly on the website, ohri.ca/Ottawa Method Center. And so that will trigger a triage, and we go through our requests, reach back out to everyone. You're set up with a free consultation to see how we can address your needs, and then work with you to see how best we can support you. If you have a really quick, short question that doesn't need a consult, you can also even ask a question directly on the Method Center website. So do use that resource if you think that can be helpful. Next and last slide, but of course, also reach out to me directly if I can be helpful. And I'll leave it at that if anybody has any questions.
Thank you so much, Justin. I will acknowledge that you have entirely convinced me that you well appreciate the learning health system action framework, and that your center is set to support all aspects of it. And I think we're seeing in the chat a little bit around the opportunities people are seeing, and people actually are sharing some evidence back and forth about current programs in Ontario, like Best Care for COPD as an example. And I think this is a good forum and bringing the opportunities to make sure that evidence that your center has created. So really, thank you for sharing Optimize work, which I presume is available online, right?
Yes, exactly. Yep.
Yeah. So again, opportunities for people to look and find where they didn't know about you before, to learn and know that there's a place to go and look for those existing resources, and then also about possibly engaging with your center on some of the additional resources and the wealth of knowledge and expertise that your team has built. And somebody did ask, I think for all of our speakers today, a question around how is this work supported, what's available to OHTs, and I really said it depends a little bit on the kind of project. Like, is it something that we'll need to go get some external funding for? Is it something that we may already be funded to do it with a certain kind of partner? So I'll leave it to you to respond in whatever ways are best appreciated, or whatever makes sense in the chat. For all of our speakers today, I want to turn it over quickly on to Kaylin Moat from McMaster Health Forum and RISE to learn more about that. But do watch for the chat, and we'll continue to follow along. It's been, I think, a useful conversation also amongst the participants today, as much as questions for the speakers. Great. I'm going to turn it over to Kaylin and welcome you to come on here and share some of the work from McMaster RISE.
Great. Thanks, Walter. And thanks to the John and Diana and Justin for giving me such a great setup. I think most of my focus today is going to be on things you can do in your OHTs to self-serve getting some of these forms of evidence. But I do also point to the fact that, evidence support of the types that Justin, Diana, and John mentioned that Walter provides, among others in the province, are absolutely essential. But I hope that the big picture that I'm providing about different sources of evidence and some of the steps and prompts that you can take internally will help you and your group and your OHT kind of advance your work using best evidence as needed, and then reaching out to groups like RISE or like OHRI or Craner or HSPN when you can't find what you need to get, and you do need to engage folks who can provide you with, as Walter described it, the intro, new flows of evidence. Next slide. So I think this is pretty clear to everyone. Justin really helpfully at the end of his presentation mentioned how evidence synthesis and support really is a separate gear that we need to be focusing on, but transects all of the others. And importantly, we need to be considering the use of evidence and improvement cycles more generally, whether we're focused on the Big Bang reform decisions, such as introduction of OHTs, but all of the 1,001 organizational program decisions that you and your groups need to be making. Next slide. So evidence synthesis and support, I'll take a deep dive here. And again, as I mentioned, I'm going to really be hopefully focusing on some of what I would call self-serve stuff. But why is this gear important more generally in the context of the work that we're doing? I think Justin mentioned this and others alluded to it. It's just really helpful to be able to pull on existing evidence and rapid evidence syntheses from groups that are able to provide those to help you get a sense of what has worked, what hasn't elsewhere, what are the key components of those things that worked, when can they be adapted, or where do they have to absolutely stay in place? What conditions are key, what context matters most, and what barriers are identified when you're thinking through either a program that you're thinking of implementing, a particular clinical pathway, et cetera. So all of these things can be informed by existing evidence. So what are the benefits of things like evidence synthesis? I'm going to get into many different forms of evidence today in a second, but evidence synthesis specifically versus a single study. So I know that for those who have taken methods courses, you'll know this already, but I think it's worth reminding ourselves that an evidence synthesis ideally is a summary of what's been learned about a particular question you have from all of the studies conducted around the world on that particular question, including, when they're really well done, how this might vary by groups and contexts. And this is very different than what can be learned from a single study conducted with a single population in a single health system or region or a community. Those can be helpful as well to help you contextualize global findings, but there are some benefits to those kind of big picture global evidence syntheses. So they're likely to lead you in the right direction. So frame negatively, less likely to be misled by the results of a single study. If you're relying on evidence syntheses, it can increase your confidence that something is going to work, particularly when you have an evidence synthesis, say, includes 100 different studies, all showing the same findings. If you know that things have worked the same and the results have been the same across 100 studies over time and in many different settings for many different groups, your confidence can increase dramatically at the ability of that particular intervention, program, clinical program. Anything you're thinking of will work across different contexts. I'm not going to get into too much of the technical stuff today, but essentially, if you're looking at questions of effectiveness, so does something work? Does a program work? Does this clinical pathway or this approach to implementing a clinical pathway work? You can get more precise estimates of whether something works with a well-conducted evidence synthesis, particularly when there are many studies included. Really importantly, I don't think anyone else mentioned this, but given we know that context, issues and evidence evolve over time, increasingly we're seeing folks like Justin's group, others doing what we're calling living evidence synthesis. So regularly updating an evidence synthesis, making it publicly available. Often these are powered by artificial intelligence and machine learning. And this can help you stay abreast of any new evidence that comes out. So during COVID, this was absolutely essential as the evidence base was shifting sometimes hourly. So really important thing to note there. Next slide. So what do we mean by evidence synthesis and support? So I've already mentioned it a little bit, but when we talk about evidence synthesis, it's really two things. And I think Walter said this really succinctly. You can either pull on existing evidence syntheses that exist or engage groups like Justin's, Diana and John's, Walter's, mine, to do new rapid evidence syntheses on questions you might be looking for. So you can be pulling on the global evidence base or asking for a contextualized evidence synthesis. All of these approaches really, though, are pulling on all the best studies in the world on a particular question you might have. I've already mentioned it's a key input into Gear 3. really when you're co-designing. Justin mentioned this as well, but it's really important among all the other gears as well. And I'll get into that in a second, as I will show on the next slide as well. Other forms of evidence, we've heard about many of them today, are really important at different points in the learning and improvement cycle, and we'll talk about that in a second. But again, the focus for the next little bit is going to be on prompts that I hope will make your life easier when you're thinking through, how do I actually reach into the research world, pull out the best evidence syntheses in ways that are simple and hopefully not creating too much of a burden on my team. Next slide. So you can see here, I'll start with the fact that evidence syntheses can be done of any of the types of evidence or research that I've listed here on the screen. But just to note that there are many different types of evidence that can inform your decision-making as part of learning and improvement. So you might just be at the beginning stage, which was discussed during the last webinar of, what are the system gaps and what's driving them? What are the inequities that my OHT is facing? What priorities are addressing? So here's where you would look to things like data analytics, modeling, and qualitative insights to try and get insights about how to approach gear one. Of course, as I've already said a couple of times, you can also get evidence syntheses of all of these types of studies as well. In gear three, when you're doing co-design, of course, you'd be drawing on evaluations of similar interventions that you're considering or programs that you're considering to see if it's worked and how it's worked. Modeling studies can help you predict what might happen when you pull a particular lever, introduce a program. Qualitative insights can also help you understand how different stakeholder groups might perceive an approach you're thinking about. And of course, you can also have evidence syntheses of all of these types of studies as well from around the globe. You might also be looking here to health technology assessments, cost effectiveness analyses, and guidelines to provide you with direct recommendations about what you ought to do to address a particular problem. When you're implementing, evaluating, taking feedback and adapting in real time, which would be gear 4 and 5, you'd be drawing on many different types of evidence as well. So behavioral and implementation research with groups like Justin, qualitative insights that many of the folks on the call today spoke about, of course, evidence syntheses of all these above. And as Walter mentioned earlier, this process in and of itself should be considered an opportunity to create new flows of evidence. So you'd be doing data analytics in real time, evaluating your approaches as you're implementing them in your OHT, and contributing to the knowledge base that other groups in your OHT or other OHTs across the province can be leveraging to advance their own priorities. Next slide. So here's the quick and I hope clean enough prompt list that I think will help you and your teams be systematic and transparent in a relatively easy way when you're looking to draw on existing evidence syntheses in your work. So as I've already mentioned, it can be important in many different stages of the learning and improvement cycle. And here are the 5 prompts, which I'll get into each in turn. It's important to keep in mind that the evidence support kind of infrastructure in the province has moved very, very rapidly and changed a lot since, I would say, the last 3 years. So learning from COVID and trying to put in place those things that can help folks leverage evidence when it's needed. And ideally, these can help you do your work more efficiently. So the fact that we do have groups like Diana and John's at Craner, Justin at OHRI and HSPN, is just a real boon to our ability to leverage best evidence in our work and have greater confidence in how we're moving forward. And also something I think it's important to note that it is easy for people outside your organization to assess documents that it puts in the public domain. So consider whether or not you're using some of these prompts and taking these into consideration when your group is publishing something. Trying to be systematic and transparent will give others the confidence that they can draw on your insights from your OHT and implement it in their own setting. Next slide. So the first prompt, really confirm that it is research evidence that you actually need. So you don't always need research evidence to do everything, but certainly there are times where you do. So just a little bit of a level set, and apologies to those who, this is something that, you yawn at, but not everyone knows this. So I think that it's important to understand that research evidence has 3 important attributes at least. There's probably many more. I don't want to get too technical today, but usually when we talk about research evidence, it's an output of empirical research that was conducted systematically, reported transparently, and it doesn't matter if it was peer-reviewed or where it was published or posted. It needs to be conducted systematically, transparently. It can take one of many forms. So there's at least 5 forms of domestic evidence, 1 form of global evidence, and 2 forms of recommendations. I've already listed these in a previous slide. So domestic evidence includes things like local data analytics studies, modeling and evaluations. Global, of course, would be those evidence syntheses I've spoken about, and recommendations include things like health technology assessments, cost effectiveness analyses, and guidance. Really important is number 3. So you need to be able to assess the quality of research evidence using explicit criteria, or the credibility or risk of bias. And this really just depends on which evidence paradigm is being used. So there are many ways to take into account the quality of a piece of research evidence. And this is one of the kind of 3 attributes that I think are important. Now, considering other types of helpful complements to research evidence. So things like stakeholder positions and public sentiment. So there are methods that are used to get those, but we wouldn't necessarily consider those research evidence. Internal policy documents and what other jurisdictions are doing aren't necessarily always research evidence, in our opinion. Lived experiences sometimes can be reflected in well-conducted, systematically and reported transparently designs, but not always. So these wouldn't necessarily be considered research evidence. And there's many others listed there just as a bit of a level set. When we talk about research evidence, the 3 attributes are what we're talking about. Next slide. So if you have determined that research is what you need, then I think it's helpful to use a framework to orient yourself to going into the research evidence and identifying what you need. Because as I've already mentioned, depending on where you are at in the learning improvement cycle, it could be a different form or a different type. So there's policy analyses frameworks, there's program analysis frameworks that can ask similar but slightly differently framed questions. There's systems analysis frameworks to trying to understand things like, do we shift governance, financial and delivery arrangements, or put in place different implementation strategies to make sure that we're getting people the program services and products that they need. And there's also many additional frameworks that can add value as part of all of this. So they can be sector specific. They can be things like I know Justin and his group use quite a bit, like the COM-B when you're thinking through behavioral and implementation science frameworks, and equity analyses, which are coming up a lot and are very important. And I think there's a lot of frameworks that you can leverage there. The important thing is that having a framework or an approach in can be super helpful. Next slide. So here's an example of how, depending on the framework you use, different forms of evidence might be useful. So if you're taking the policy analysis framework I spoke to on the last slide, noting here the similarities with the learning and improvement cycles, very similar. Trying to understand a problem and its causes might leverage things like data analytics or modeling, but when you're thinking about selecting options, you could be drawing on different forms of evidence as well, like guidance and technology assessments. Of course, evidence syntheses can weigh in here as well across all these stages. The important thing is that the framework is a super helpful way of structuring your approach to identifying what evidence you actually need, if it is research that you do need, because as you can see, depending on where you are and the questions you're trying to answer, it can vary depending on that component. Next slide. So this is, I think, the key thing that I hoped folks could walk away with, trying to make your life easier. So there are important repositories of existing evidence syntheses that are already quality rated for you, that you can draw on today if you wanted to get insights from best evidence about the problems that you're dealing with or you're thinking through in your OHT, what solutions you might be co-designing with your patient, family caregiver partners, etc. So if your question is more on the clinical programs, services, and products, so which types of treatments or programs do we need to put in place now? Access is a key database that you can consider. And I provide the links at the end of this as well, and I'm sure that we'll circulate the slides to the participants today, so you'll get these. If your question is more about public health programs and services, then health evidence would be your place to go. If you're looking at health system governance, financial delivery arrangements, and implementation strategies, health systems evidence is where you might go. And similarly for social system arrangements, plus program and service areas outside of health, so in non-health sectors, then social systems evidence might be a place that you consider going. So all of these have quality appraised evidence syntheses for you to draw on. Oftentimes, they have already organized the studies by things that might correspond to any MISI framework, or mutually exclusive collectively exhaustive framework that you've adopted. So it could be that you're looking for particular types of evidence syntheses. It could be that you're looking for particular approaches to program design, different system arrangements, like how to pay primary care physicians differently. You might be looking at different populations. The good thing about these repositories is that you can go in through any of these windows and rapidly find evidence and identify whether it's high quality, low quality, because it's been pre-appraised for you. You might also be able to look for a filter for living evidence syntheses already that you can pull on and get updates about occasionally. There are other forms of domestic evidence that you can kind of look into, as I've already said on the other slides. These repositories are quite easy to use in and of themselves, but they're often designed more for researchers who are doing their own evidence synthesis. So they're helpful. You might go in and search. Increasingly, like places like PubMed are getting better for helping you do quick searches. But these are the types of places you might look for domestic studies and in particular evaluations in your topic area that were conducted in Ontario. Next slide. Once you've got the evidence in place, and as I've said on the last slide, the places I'm pointing you to are already quality appraised, but you really want to look at a piece of evidence that you've identified and saying, is this of broad relevance to the scope of my area of interest? So is this something that's aligning with the framework that I've developed? Am I looking at a problem, and is this helping me answer my question about a problem, or am I looking for a particular population? So it seems easy, but I think looking through these steps can help you structure your thinking and hopefully reduce the chaos that might ensue if you didn't have something like this otherwise. So the second step here is confirming the specific relevance to the question being asked. So, as I've showed on the other slide, there are different types of studies and systematic reviews that you might, or evidence syntheses that you might draw on, depending on where you are in your learning and improvement cycle. So you can ask that question too. So is this relevant, answering the part of the question that I'm interested in? Number 3 here, really important, identifying what the best evidence is for your question. So ideally, you'll have an ability to do a quality appraisal if it's not done already. The places I pointed you towards already have that done for you. That's part of the plan today. So using things like an AmStar rating, and ideally, you're not assessing quality based on poor proxies. So credibility of an author or credibility of the organization that produced the work is not a good proxy for high quality research evidence. Whether something has been peer reviewed, as I've said before, is not a good proxy for high quality research evidence. Certainly, there are lots of published peer reviewed evidence syntheses out there that aren't done to a high standard. Availability of a grade profile is going to be helpful for those particularly interested in whether or not something works. So something like a grade profile, you may have heard of this before, can tell you how much certainty you can place in the findings of a particular evidence synthesis you identified. Ideally, something has been done within the last 5 years. That's what our cutoff date is when we're considering currency and recency. And you might look to things like the countries studied and included, and it should say synthesis there, because that can help you understand whether or not the findings from that particular synthesis are relevant to your own settings. So if you're able to get to this stage and you are kind of thinking through, well, how do I organize this in a way that's going to help my team understand it? We often think through things like organizing all of the studies we find based on our framework. So it could be you have a particular section for population A, and here's all the studies we found. We also find that it could be helpful for readers to navigate this by providing a statement of what was found in the evidence synthesis and providing a link to any publicly available versions of that document. Next slide. And then moving on, I think this is also key. So I'm not going to spend too much time on this, but I think it's important to realize that when we think about high-performing evidence support units like the ones that we've been exposed to earlier on in this call, it's important to work with them to clarify the form of evidence you're looking for. As I've already said a number of times, there's many different forms of evidence, and you might need one and not the other. It could be that your question requires you need all forms of domestic and global evidence, but I think it's helpful to engage folks like Justin, Diana, and John with a little bit of an understanding and working with them to try and clarify whether it's data analytics you might need, modeling, evaluation, behavioral implementation, research, qualitative insights, It could be that you're just looking for an evidence synthesis of the best available global evidence, and it could be that you're looking for recommendations on how to proceed with a particular course of action. So all of these could be in the remit of a group like Justin's, Diana, or John's, but it's important to work with them to clarify what that is. And I think the slide I showed earlier where I was mapping different forms of evidence to the learning improvement cycle can be a helpful starting point for you in your OHT. I think it's also important to decide whether or not you're wanting to engage in a specific trade. So different groups have different, I would say, areas of expertise. So our group at RISE would be, for those of you who have been exposed to the McMaster Health Forum side, consider ourselves, more of a specific trade that can do things like rapid evidence syntheses for your questions, but there might be others that you engage that can help you navigate all of their partners. So if you need a data analytics study, they can point you to the right data analytics folks, et cetera, et cetera. So I'm not going to speak for others on this call, but there might be ways to consider them general contractors to make connections with different points of expertise across the province there. I think it's important to look at different websites to see what self-serve options are available. Justin mentioned that they post all of their things publicly and the outputs of their research publicly on their website. So that's an example. I'm sure John and Diana do the same for Craner. And it might also be helpful to look at the website of groups who are providing evidence support to determine the types of products and processes that they can help you with. So for example, rapid syntheses or living products, or maybe it's something like a rapid qualitative assessment of views and experiences from a particular population. Next slide. So here's just a quick example of the McMaster Health Forum /RISE. So here's how we provide people access to our own products. Next slide. And I've already mentioned these repositories that we manage. Walter mentioned these earlier. Part of what we do at the McMaster Health Forum and use to underpin the work that we do at RISE is manage 3 databases. So one on health systems, one on social systems, one on COVID-19. These are all examples of self-serve. So what we mean by that is you'd go to these websites and be able to reach into the research world and pull it out just in time for when you need it. Moving on to the next slide. We also provide evidence support in the same way that Justin, Diana, and John have already mentioned. So here's just it's a half screen. I didn't have a chance to pull everything in. The scrolling wasn't working properly, but we can provide people with rapid evidence syntheses as well. So whether it's a rapid evidence profile or a full synthesis or living versions of those two things, we can do these in rapid timeframes for folks when they have questions that relate to kind of programs and systems type questions. So next slide is going back to thinking through that Ontario has a range of folks available to provide you with evidence support. Many of them we've spoken about today, we've heard from, and others you'll see there like Inspire, RISE and OSM for those working in the north, HSPN, of course, I would say RABE as well at the Ministry of Health, and I see Jeffrey on the line today. All of these are types of groups around the province who can provide you with evidence support in a timely, demand-driven way, and they're linked to support decision-making up to advisory and decision-making processes as well as out to learning and improvement platforms. So this is our best take at trying to organize all of the groups across the province that can provide this type of support by type of evidence that I mentioned. But note that as we've seen in the presentations today, there are many areas of overlap here. So it's not as though just because we're written into one area, it means that that's all we can do. Next slide. And relating back to step 3, which I saw someone in the chat box helpfully say, this is the slide. Well, here are the links to the 4, I think, key databases that if you and your OHT are working on trying to pull in best evidence from evidence syntheses, here is where you would go for the different types of questions. So again, access for clinical programs and services, health evidence for public health programs and services, health systems evidence for health systems questions, and social systems evidence for things outside of health. And these are all free public resources for you to use. I don't think it's that weird. McMaster's known for evidence stuff. So all of these databases are run by different groups. We're not always, working together, but we coordinate when we can on these. But these are all based out of McMaster because we think, having access to free, quality appraised evidence syntheses is a great way to help you increase the likelihood that you'll use best available evidence and evidence syntheses when you can. So I'll stop there. Walter, hand it back to you. And sorry if I took more time than I expected.
Oh, not at all. I'm such a wealth of experience shared today across the three programs. I mean, I really think on that evidence synthesis, like such a powerhouse. And there are so many topics that have already been covered because you've done so many at varying levels. And I do know that sometimes can be available to answer those questions, particularly the shorter term ones that are, maybe not a complete systematic review, but a quick rapid synthesis, which is often, I think, OHTs are just looking for some ideas to get started. So it can be a hugely useful resource. And many of the topics I think that have been raised in Ontario before are available through your site. I think on the comprehensiveness of the Ottawa Centre and Justin's review of really showing how their centre touches on and can support every element of the learning health system, all 5 gears. Such depth and breadth across that center. I mean, I think even, for us here at HSPN, we support in various ways, many of them, but really we're mostly on the upfront data and the downstream evidence. And then we really try and support, evaluation. And we really try and support others to know that they need to have this evidence synthesis, not something we do a lot of, and that they really need to do the co-design and work and really be very thoughtful about implementation and even crossing over now. Justin talked about the evidence synthesis being used to generate and be part of the formation in that co-design work. And I think that's really it's quite thoughtful about how the different gears order matter, and they need to push the next gear. Data needs to push towards what evidence is needed. Evidence needs to push towards co-design. Co-design needs to push towards the implementation, and then the implementation needing to push into the evaluation. So thinking about the more we learn to work with these gears, the more we understand how they actually need to happen and work in detail. And from NOSM's perspective, really thinking about the local understanding, and I think having centers like Craner that really understand that northern rural health. And we were having a conversation the other day, like even on the data side, understanding what it means for data sample sizes and things, and having small cells, which is quite important for understanding what data can be shared, and then also to understand that it can still be very meaningful even with small counts, because that is actually the population in the area. So I invite everybody to popped in the chat. The first one around the feedback on today's webinars, your thoughts, pros, cons, and ideas for further. And actually, if you have suggestions or lingering questions, use that link to put those out there. Also feel free to get back. We had a couple extra questions here that are still floating, and I strongly recommend we continue to use these in the next couple of events that are shared. So just a little highlight reminder to people that we are in the midst of this whole series on the learning health system, and that they are running on the 4th Tuesday of the month. We always run, we're up to about 40 of these now. 12 to 1:30, 4th Tuesday of the month, upcoming in July and September. We have co-design, implementation, and in October, evaluation. So I just want to welcome everybody and thank especially Justin, Kaylin, Diana, John, and for coming today and sharing with us. I really appreciate your being able to do that. And maybe we could pop on screen just for a little last thank you and goodbye. And it's really, I think, a great opportunity to share and to get to know each other a little bit better, both amongst ourselves, but I think we know each other a little bit, but especially with OHTs, and letting the OHTs that are trying to make a difference in people's lives, that there's a rich set of resources here in Ontario that they can draw on. And this is, there are more beyond us, but I think it's a really nice overview of the kinds of resources that can help support a learning health system moving forward. So thank you very much again. Welcome to everybody for joining us today. And as I said, the slides will be posted, webinars you can share, you can come back for the links, and please do use that link for feedback and carry on the conversation. Best wishes, everybody. Have a lovely afternoon.